Presentation is by Dr. Suven Bhattacharya. You all know that Dr. Suven is an international figure in ophthalmic surgeons field, and he is famous for his new device, that is BHATS, and we all are using that BHATS device now at present. And he is going to talk about the small pupil management along with the hard cataract and managing with the new devices. So over to you, Dr. Suven Bhattacharya.
Yep. Thank you, Dr. Rajendra Prasad. A wonderful course as always, and I must congratulate you on the Terminator. Though I don't personally use it, but I have seen I have very rich praise for this for the people who use it. I'm more comfortable keeping my hard nucleus inside the bag. So let's see how we deal with this on this topic. Small pupil and hard cataracts managing with new devices. I do have a financial interest in the BHEX Pupil Expander, and I acknowledge the contribution of Dr. Deepak Megur for the videos that I have borrowed. So now when we look at small pupil and hard cataract, I think it's most important for each one of us to know our comfort zone. Pupil size vis-a-vis the hardness. There is always each one of us which we have our own sweet spots. So I would recommend that you use a pupil device, any device, when you have a hard cataract and a small pupil, because the central corneal endothelial damage is going to be much more in a hard cataract. Often these hard cataracts are associated with comorbidities like pseudoexfoliation and subluxation. They also, if there is pseudoexfoliation, there's likely to be a rigid pupil, and intraoperative myosis may be difficult to handle with more attended complications. So you must. Now, if you choose not to use a device, like many surgeons are very fond of not using a device, I would like to ask you that if you have a hard cataract and a non-dilating 4 millimeter pupil, and a very skilled surgeon is operating, what would you prefer? The surgeon use only skill and no device, or the surgeon use pupil device and skill? I guess since availability and cost both are not an issue, it's better to be safe than sorry. So if you're not using a device, I think it's better to be prepared for intraop myosis, and earlier the call, easier the going. Before, there are different stages where you would find different stages, different intensity of difficulty before the capsulorhexis, after the capsulorhexis, and before nucleus disassembly, and during the nucleus disassembly. So it's best to do it as early as possible. So let's talk about the BHEX Pupil Expander. It's a 75 micron device which has a circumcircle of 7 millimeters, 6 notches, 6 flanges, all in a single plane. It comes in a preloaded housing, transparent housing. You just need to advance it from the housing into the eye and place it on the iris, and then tuck alternate flanges under the pupil margin. And you have a wonderfully dilated hexagonal pupil, which is a 5.5 millimeter pupil. It's a univalent planar device, so the iris bends, but the device remains in the same plane. Removal has never been easier. Through the main incision, it's always a cakewalk. And the best thing is you can even remove it through a 1 millimeter side port incision. So the BX, as I said, is as thin as a human hair, 75 microns. That is the thinnest device available. And that's the reason why it can work out through a 1 millimeter side port. So that's the packaging and the device, preloaded device. For all new users, we would recommend using the get a pack of 5, and the BX 23 gauge forceps is a necessary accessory because that is what is useful in manipulations. Anything else used will not really give you the desired results, and you may be unhappy. So this is a comprehensive solution for small pupil. It's a simple design, user-friendly, tissue-safe, and affordable. And of course, it's a no-brainer. So how big do you want the pupil to be? Now, that's a big question, especially in hard cataracts. Often it's with iris hooks or other devices, we want them to be pretty big so that, that is just is a psychological advantage. But if you ask yourself, aren't we all skilled to perform phaco through a 5.5 millimeter pupil, which will not get smaller? And that assurance is given by BHEX. And I would recommend that even if you're using iris hooks, not to keep your pupil larger than 5.5. That is not good for the health of the pupillary margin. You may have defects, and which may cause a lot of glare in the post-op period. So you need to differentiate the elastic and the rigid pupil. The elastic any pupil expander would work. It's like a rubber band, whereas the non-elastic one is like a string, so you need to tear it or break it. So you need a strong and bulky pupil expander, or you could use a Coughlin hook, a pair of Coughlin hooks. So let's see the steps in the BHEX. So you need to inject viscoelastic under the pupil margin and lift off that pupil margin a little bit, and take the device and place it on the iris, and then start tucking each flange. Alternate flanges are tucked, and that's the first flange which goes under the pupil margin. These tabs with holes are more for identification and easy manipulation. Otherwise, these holes are not to be used for any inserting any manipulator through them. And there goes the last flange under the pupil margin, and you have a wonderful hexagonal pupil. So it's a very simple, user-friendly device, does not require a learning curve, intuitive. Now let's see a hard cataract. Anything less than 4 millimeters and a rigid pupil, I would always recommend that you stretch for any device, even for iris hooks. That gives you a nice round pupil in the post-op period. So this is a pretty hard cataract. For those who think that you require a larger pupil size for a hard cataract, well, you see, this is a pretty hard cataract. All you need to do is chop it into as many small fragments as you can. What method of chopping you use? You could use Dr. Rajendra Prasad's the terminal chop, or the direct chop, or even a stop and chop if you're comfortable doing that. But as long as you chop it into small fragments, 5.5 is a very good size for any hardness of cataract. And the BHEX, like I said, works out very easily through the incision. And it's good enough for any maneuver of yours. Now, this is a shallow antechamber. There again, the BHEX has a huge role because of the thin profile that it has. So it's a 75 micron device, whereas anything like a Mulligan ring is 0.9 millimeters. And that, when it's placed in the mid-peripheral antechamber, the corners, that could be a touch and go in a shallow antechamber. So because the mid-peripheral AC is shallower than the central antechamber. So like you see over here, it's a shallow antechamber, yet it's so easy to tuck these flanges under the pupil margin under direct visualization, so that you have no issues of endothelial touch or damaging the capsule. If you're comfortable doing your capsular rhexis and then the phaco, and in this case there was slight zonular dialysis, so CTR also could be used very comfortably, and of course IOL placement. And removal of the BHEX is very easy as usual. So, sorry, let's go back. Yep, so this is a case where we have intraoperative myosis, and let's see how the BHEX helps the situation. So now this is a pretty hard cataract. So the pupil has come down. I still have a heminucleus of hard cataract there. At this stage, I take a call that I would probably require to use a device. So this pupil will not dilate with metronidine. So you use BHEX, the viscoelastic under the pupil margin over the capsular rim, and lift off that pupillary margin. And then, now the advantage over here is with the BHEX is you can tuck those flanges without engaging the capsular rhexis margin, because you're doing it under direct visualization. And even if you do engage, you can retract and go back, which you can't do with a remote held device like a Mulligan ring or others. So you have instant confirmation that you have not engaged the capsular rhexis margin as soon as you're tucking the device and you push it to the periphery. So once you have that 5.5 pupil, you are in a comfort zone, and you can deal with any hardness of cataract or any complication that you might have had. So now, like I said, when you have an intraoperative myosis, a device like a Mulligan ring, when you are watching to the top view, the scrolls or the pockets are on the side. So you cannot see the gap very well. So it's very difficult to align it to the pupil margin. So there is every chance that you will engage the capsular rhexis margin, and that would be a disaster. Whereas in the BHEX, the gaps in the notches are clearly visible from a top view, and it engages the pupil margin with certainty. So let's see this video from Dr. Deepak Magur. So capsular rhexis is done, nucleus rotated a bit, and he starts the phaco, and this is a hard cataract. And at this point, he decides, no, it will not be possible to do a phaco without a device. So he goes ahead, injects viscoelastic under the pupil margin. Like I said, lift off that pupillary margin, and then tuck those flanges with instant confirmation that you have not engaged the capsular rhexis margin. And then you have your comfort zone. The BHEX is the only device, only pupil expander which can be removed through a tiny 1 millimeter side port incision. And that is a huge plus when you're dealing with iris prolapse and IFS. As we know that IFS, the iris prolapse would be from the main port, side port, so any which port which allows you a little bit of comfort, you could remove that device. And even when the antechamber is shallow, that is a huge blessing. If you're interested in reading more about the BHEX Pupil Expander and the tips and tricks, I would invite you to download this document. It's a PDF, it has video links running alongside the text, and you need to click on the link to reach the exact scene. You could download it from the website. The page is BHEX Pupil Expander, and the subpage is ophthalmic surgeon. You could read my 10 tips on phacoemulsification in small pupil at eophta.com. Thank you very much for your kind attention, and thank you, Dr. Rajendra Prasad, again for this invitation. Sorry, let me stop. What happened?
Unmute yourself.
Yeah, I can unmute.
Dr. Rajendra, unmute yourself.
Yeah. Thank you, Dr. Suven, for the excellent video presentation and your device BHEX, which is now, I think, is the choice of pupil expander at present all over the world. And people especially looking for BHEX only instead of Maligin, because I used both Maligin. I really find very difficult the implantation as well as the extraction removal of the Maligin ring is not very easy. On the other hand, the BHEX is very simple, and putting it in and taking it out is so easy. Like, it's very comfortable. And all the advantages with BHEX, and I think we all should use it. And excellent video presentation, Dr. Suven, really good. Dr. Vinod and Dr. Arvind, any question to Dr. Suven?
Yes, there's one question from Dr. Kiranji. He wanted to know whether the oval pupil is more helpful in doing hard cataract. It will give you more choice to see the end and other things.
I think the question was directed to Dr. Arvind Moria and Dr. Rajendra Prasad right in the beginning, where he wanted to know whether the terminal chop, the oval rhexis would be relevant. So maybe Dr. RP or Dr. Moria can answer, because they are using terminal chop.
Yeah. The oval rhexis, we have been working on it, and I spoke to Dr. Kiranjit earlier also, and I'm working on this, and we are, Dr. Arvind and myself, we are getting ready with a publication also on oval rhexis with terminal chop, and Dr. Kiranjit is going to be part of that also, and it's in the process. And the second important point which I wanted to bring out was, like Dr. Suven said when Dr. Arvind was presenting, like in terminal chop, you bring the nucleus out. No, not at all. So this is the misconception. Actually, we do not bring the nucleus out at all. Nucleus is always within the capsular bag. It's only when you're holding the nucleus within the equator, you're just slightly drawing it. You're drawing the nuclear edge to see the edge of the nucleus within the capsular bag. It's never out of the capsular bag. And this drawing is just to hook the equator of the nucleus with the terminator, so that you get a crack at the equator itself. We never bring out the nucleus out of the capsule. This is absolutely misconception. So nucleus is always within the capsular bag, and it's the simplest way to crack the nucleus. And I think because to use horizontal chop or to use the vertical chop, you need a lot of experience, because you need a lot of practice, because I started long back, and it took me almost 10 years to learn it properly. And this terminal chop, now I come across just first year resident. He comes to me, says, sir, it's so simple to us using this technique. It's really simple. You get a complete crack. So that is what I just wanted to put in on. And the oval rhexis would definitely help us, because if hooking the nucleus, if you have oval rhexis, go along the longer side of the rhexis and hook the nucleus, so it becomes still easier. So we are working on it. It's beautiful to have the oval rhexis with the terminal chop technique.
I think you're just lifting the pole inside the bag only.
Yes.
You're lifting one pole that is inside the bag only.
Yeah, without damaging that rhexis margin.
Yeah, without damaging the rhexis. It's within the capsular bag only.
Yeah.
Thank you, Suven, for the
thank you
presentation. Always pleasure to see your videos and your presentation, and thank you.